Nilanjarian, start. You can start, Nilanjarian.
Sir, unmute your mic, sir.
Okay, done.
We can start, sir.
Yes, ma'am. I'm taking my.
Yes, sir. Yes, sir. Yes, sir.
Okay, is everything good?
Yes, fine, sir.
Okay. Good evening to all members. So today's session would be on training on standing up in stroke patients. Is it mandatory to train a patient in standing? If you ask me, I'll say it is mandatory. Why? Because normally patient in stroke, they lose ability to stand up. Is standing up a really big task? Yes. For today's session of class, we would see the objectives such as today's session will be about biomechanics and description of standing up. And kinematics and kinetics of standing up. STS means it is standing up under different conditions, and muscle activities or muscle involved in this activity is what is going to be today's session of class. So now, let me just introduce about standing and sitting. Is standing up and sitting down are really essential in independent of daily life. The ability of standing up we call it to be in neurology called to be STS, and sitting down we call it to be SIT. Is essential to an independent lifestyle, because without sitting and standing we cannot do any of the functional activities. So standing up is prerequisite for other action such as overground or stair climbing. So normally to walk or to do an stairs climbing, the prerequisite is standing up from a chair. So which is a big problem or difficult condition happens after a patient having a stroke. In daily life, a able person stands up on an average of 4 times an hour. We are all human beings. We cannot be just idle like that, sitting for a long time. We are social humans, so we are supposed to move in and around. So what we do is we move around, or we get up for our active daily living at least 4 times each hour. Standing up is one of the most mechanical, demanding of inactivity of daily living, requiring greater range of motion at the knee and higher momentum in force at the both hip, knee, than gait or stair climbing. See, why do I say this? Because stair climbing is usage of some force that happens in the feet, knee, and ankle. But the force required for standing up from a chair is really in greater demand of force required, because the person really requires extra energy, extra force to push him, he has push up from the chair in standing position. The lower limb muscle strength are really important. The person should have a good balance, and control of the body segment linkage are therefore critical for effective performances. So I said once again, go back to the words here. Lower limb muscles require abnormal strength, means they should be having very good strength. They should have a good balance and control of the human segments. Linkage are therefore critical in effective performances. So there should be a good balance, strength in the muscles, and there should be a control in all these three, so that the patient does an activity of daily living effectively. So this is the slide that you're viewing is the process or the overall position where the patient or the person is going to get up from sitting to standing. I request all the participants to be most probably better that you all sit and appreciate what I'm telling, so that you also can perform it on yourself, so it can really be enjoyable, or it's more understandable. So you can see this picture, a lady how she sits back, and you can also look how she is moving from sitting to standing. So I want you all to check the ankle, knee, hip, and thoracic region, how it moves. When the patient moves from sitting to standing. Are you able to follow my presentation?
Yes,
Are you
sir.
able to? Okay, good. So are you able to view my PPT?
Yes, sir.
Good, good. Thank you. So I said I request all the participants better be seated in a position in a chair so that you can appreciate the muscle activity or the force that you really generate. So following stroke, the patient or the person is problem is unable to stand up is very common. This limits the independence of participation in the activity of daily living, which further decreases the muscle strength. You all know that when you don't appropriately squeeze the muscle, they lose the strength. I means that you don't contract the muscle, they lose their property. So likewise, the physical fitness, which leads to adaptive changes, especially in soft muscles, soft tissues, in soleus muscle. Because one of the muscle that goes for tightness or changes, rapid changes in lower limbs, one of the muscle is soleus, because of the adaptive changes happening in soft tissues. So we like to bring down this, or we like to decrease the problem. So the only thing is that we make the patient independent. So the problem here that we find here is the patient is limited with independence. So we are breaking it and making the patient or the person independent in his activity or daily living. So why am I focusing on standing? So normally in geriatric or patient with stroke, they have difficulty in standing. A patient normally comes with a stroke. They normally come with a complaints that they have a fall, frequent fall, or when they fall when they get up from the chair. The most common that you see in many of the articles or journals or many of the books that says this, the patient has fallen from the wheelchair when he was trying to get up. What does this show us? This tells us that patient has got a problem in standing up. Means that the fall is one of the main problem next to stroke. That's going to injure the joint or the muscle or the bone, whatever it is. So the above is due to deficit of the muscle strength and improper or doesn't have a good postural stability soon after the stroke. So our focus or our idea is to strengthen the muscle and to increase the stability in posture. So I said that one of the objective was to just touch or brush the biomechanic description standing up. So I said STS means it is standing up. This requires a translation of body mass. So we said here, I talk about the mass in horizontal and vertical direction. So I say, what is horizontal? So I said, I appreciate that people who are reviewing this session or attending session to be seated so you understand a better way. So in a horizontal and vertical direction and from a relatively stable sitting position. So when you stand up, your body moves first horizontally, means your trunk and your body, your I say thoracic region and your abdominal region or thoracic region, you call it a plank that moves from horizontal to vertical, then goes directly. As means that like this, they're going to move and going to go up straight directly. So this is the problem when the thigh and the feet are the base of support. The patient has got a good support, is very much productive, and when the patient's thigh is off, he loses his stability. That's what we say here. When the thigh and the feet are in the as a base, the support is good. The period is relative instability when the thigh leaves the seat and the feet becomes the base of support. So in standing up, when the patient is seated on a chair with the back support or with the armrest chair, is fine enough. When he likes to move, when he wants to come to a standing position, what he does is he has to move forward and he has to go for an vertical direction. Means that he has to move horizontally first, then go for a vertical direction upwards. When he does this, the thigh has to leave the seat. So the base of support is being decreased to a small area at the foot. So when this happens, the patient requires a lot of base of support, muscle contraction, and also has good stability. So the angular linear momentum to perform the horizontal to vertical translatory movements, the body mass is potentially destabilizing. The stability is less at the time of thigh is up on the seat. That's what we're talking about. So when the patient is moving, I said it's not, we don't move very slowly. Normally when we move at a greater momentum. The body moves as a plank or with a one segment from horizontal to vertical. So when this happens, the patient normally has to have a destabilizing region. So what we like to do is we like to enhance the patient in this region, especially in the upcoming slides. So stability is less at this time when the thigh is away from the seat. So I said what I'm talking about, the angular displacement of upper body, head, arm, and trunk. We normally call it to be a plank. Pivoting at the hips changes from flexion to extension. So all these three, I say in the head, arm, the trunk, all roll on the hip. Means they're going to have an movement on the hip. So the whole part of the body moves over the hip. The patient is going to have an flexion, then going to have an extension of the hip region. The linear momentum of the body mass changes from horizontal to vertical. Means the patient is about to rise. Normally, it's very hard to break. When you even ask someone to stop at the middle of the standing posture or his position, it's really an hard thing to stop because the muscle contraction is very vastly working enormously. So normally it's very, even for a healthy person or for a normal person, it's hard to break the process of getting up to from sitting to standing. So braking forces are required to control horizontal momentum, ensuring a stable transition from horizontal to vertical movements. I say this, even this in a normal person, it's very hard to control. But you think about a person who's got a stroke or insult to his brain, so where the tissue doesn't work or doesn't have an imbalance. You try to ask this patient to stop, or he's going to have some adherence or some breakage in his this movement. This is going to be a problem in the patient. This is where he falls down. This is the area where he falls down. So the translation of the mass forward depends on the strength, control of the muscle across the hip, knee, and ankle. So we are supposed to see that the patient has got a good strength, control. Especially where do I like to see this? I like to see this on the muscles on the hip, knee, and ankle because they are the core muscles which help the patient in moving the body from sitting to stand. It's a really, as you ask me, you ask me a question. Is it such a big task? Yes. This is even a force that you will require more than you climbing a stairs because the muscle contraction in from sitting to standing is really enormous. You'll see in upcoming slides as well. The muscle generates required force to support and balance the body mass and also in vertical direction. So muscle generate required forces. Also muscle has to contract itself in pulling up the body, and also the body has to support and balance the body mass in vertical direction. Means vertical direction here literally means patient or the person is in standing position. So the muscle generates really an enormous, means really 100 times of the body weight to support the balance the body mass and also in a vertical direction. So we divide the standing up into two phases for better understanding. So we call it to be free extension phase and extension phase. Before I move to the slides, I like to explain you what is free extension phase and extension phase. Free extension phase is that you are preparing yourself for standing. Means that the body, the thigh is still on the seat. This is about the movement of the foot, movement of the thoracic region, movement of the hip. So that stops the pre-extension phase. Extension phase is where the whole body goes up vertically or straight up, where the base of support is only on the foot. We call this to be an extension phase. We will see this phases in the upcoming slides as well. So the phase starts at the thigh off. The continuous translatory movements of the body mass horizontally, changing the moment vertically without any pause. So whenever you want to do this, make sure that there's no pause in the process of standing it. So how does the muscles and the joints work? You all would have, by this time, you would have checked this. When you stand up from your chair, are your foot really fixed as they are? When you stand up, I will say no. There are some alterations in your foot. Means that there's going to be some alteration in your hip joint, knee joint before you're going to stand up. Your preparatory phase called the pre-extension phase. The foot is placed well back. Means that, are you all trying this? Yes, please. If you're not doing it, please try this. Only then you'll understand. When you want to stand up, you cannot just stand up like that. You like to pull your foot few centimeters behind the normal face. Only this can have a push, or this can give a ground reaction force in making you to stand up. The foot is placed well back, which helps the upper body to rotate forward at the hip and allow lower limb muscle activate and segmental movement happens. So how do you start with? We start with the muscle contraction. Where does it happen? First, it happens at the ankle joint, then followed by the hip and the upper body. This generates a posterior directed components of ground reaction force, thus propelling the body mass forward. So what does we do? For a normal person, we will normally use our foot. Means that your ankle joint has gone for an dorsiflexion. So it's 70 degrees by this time. You will see that. So 70 degrees. So this, when you push your foot down, this ground reaction force will make your body to move upwards. So now, can you all see this picture? The down is going to be the dot is going to be the knee, and the square is going to be the hip, and the arrows are going to be the shoulders. So can you see how the angle changes when the patient or the person from sitting to standing is being done? So you all go across these points. What happens in the knee? What happens in the hip? And look at the shoulders. So the more changes happens at the hip and the knee. The ankle is stable. Means that the patient is going to have a lot of muscle activity at the ankle and knee. Moreover, the muscle has to be stability has to be in greater in case of this movement. So in standing up, the pelvis and spine move as one segment, as it's called a plank or a trunk. So we don't move the neck separately, we don't move the thoracic separately, or we don't move the lower ribs separately. So they all three move as a one segment. Rotation forward of the trunk by flexion of the hip together with rotation of the trunk and dorsiflexion of the ankle moves the body mass forward over the foot. So I repeat the words here. Rotation forward of the trunk by flexion of the hip means that the trunk is rotating on the hip together as one segment along with the trunk, and there's also the same time there's going to be dorsiflexion of the ankle. It all happens simultaneously. This doesn't happen one after another because we all coordinated. So when you like to stand up, your legs start automatically goes behind. There's going to be dorsiflexion of your ankle, and the body moves as a forward. Means I say it's going to be moving horizontally, and your body is going to prepare for getting up. It moves body mass forward over the foot. So slowly the weight is going to be transferred, or weight is being transferred to the foot. Now your body is ready to do this. So now your body is almost ready to leave the thigh. So your thigh is going to be away from the chair. So this we call to be pushing up, or the body is going to be pushed up. We call it to be a vertical movement. The vertical movement is brought about by extension of the hip, knee, and ankle. So muscles all have started to contract now. So the upper body is already ready to move. The ankles are ready to, with dorsiflexion ready to contract. Now the body likes to move up now. So the vertical movement is brought by the extension of the hip, knee, and ankle. In a typical sequence, on sets, the knee starts to extend. This happens at the thigh off. When the thigh is away from your chair, then the weight is going to be on the knee and the ankle. So before the hip and the knee happens. The feet are on the supporting surface. The horizontal to vertical ground traction force plays an important part in this movement. So, unless there's going to be an opposite force, you cannot stand up. So you push down, that pushes you up. So the foot that how much ever you're going to press down is going to push you up, means the body is going to be moved from horizontal to vertical. So it does make you understand in hemiplegic or in a stroke patient, what happens is the patient is not going to have an foot flat. You're not able to bring it forward. When you're going to pull him in front, he's going to have a skid, or his foot is going to go forward. So he's going to topple or going to fall. So before you do this on a stroke patient, you're supposed to fix his foot on the ground before you do this action. Prior to the thigh off, horizontal ground traction force generated in posterior direction serve to propel the body mass forward. So there's going to be a great muscle contraction along with the ground traction force. Is going to pull the body in forward direction. Now the thigh is going to be away from the chair, means that the only support is going to be the foot. The foot is going to be the only base of support. At thigh off, there is a rapid rise in amplitude of vertical ground traction force to the peak of approximately 150% of your body weight, depending on the factors such as speed. See, what does this words tell me here? So when thighs away, you don't, I say we do normally, we don't do it slowly, we get up fast. When something is very urgent, we would move faster. So this will require different muscle power required to pull the body from down to up. So how much does it normally take? It takes around nearly 150 of the body weight, depending on factors such as speed. So if you want to be, something is urgent, you are pulling your body faster. So the muscle activity or the force would be great required. The force after thigh off and stabilizing the body weight and standing is reached. So the force would stabilize or become normal when the body weight when the body weight and standing is being fully attained. So the patient, that's what we say here, the patient should have good stability and good postural care. So now, this is where it's going to be challenging things now. What do I focus on the patient when I do and standing up in patients? Several external conditions that we normally look for. Always focus on the patient's foot, its initial trunk position, speed of the movement, and seat height. These three factors will be really an important and thing that has to be focused. Without these three, the patient or the person cannot stand up. The foot placement, initial trunk position, speed of movement, and the seat height. So now, let's see how the foot moves. There are mechanical effects of different foot placement. Prior to standing, the foot is normally drawn back, posterior to the knee. That's what I've been saying you this. When you do it on yourself, when you like to stand up from sitting, your foot would normally go behind few centimeters. That's something around 10 centimeters I'm talking about. And you could see this. The ankle is something around 70 degrees to 70 degrees of dorsiflexion. Only you attain this, the patient can give a good ground reaction force. If you think that the leg or the ankle doesn't go behind 10 centimeters, you try this. It requires a greater amount of muscle contraction. Stability is lost. The patient tends to fall. This is the reason I say this. Whenever you train a patient with stroke, make sure the patient will forget this. Patient will not be able to do this. You are supposed to make the patient understand that the ankle has to go 10 centimeters behind the 90 degree, means the hip, knee, and ankle 90 degrees in normal sitting position. You try yourself. When you sit in a normal hip 90, knee 90, and ankle 90, you try to stand up, it's very high. You try this. So when you try to stand up, you can see that your ankle normally goes for an 7 degrees of dorsiflexion. So 10 centimeter is going to make as approximately. This 10 centimeter is going to make the dorsiflexion in the foot for 70 degrees. In case of hemiplegic, you see the patient going to have a 90-90-90. He cannot get up. He's going to get up. He's going to fall. Why? Because doesn't have a ground reaction force. As leg goes behind, is ground reaction force. When the leg is away, means they are counterflexed or away from the 90 degree, the patient will slip away even he stands up. So mandatory is that you make the patient, make him understand. Initially, you do it for the patient. Make sure the patient keeps like 10 centimeters from the normal 90 degrees, so that the patient attains or the person attains 70 degrees of dorsiflexion of the ankle joint. So that's what I'm talking about. Better way, I always say, I was saying that always teach the bad things first, better than the good thing. So let me tell you also this: when we do a wrong placement, what will happen? The anterior foot placement shows increased peak hip movement of force and increases the duration of expansion phase. With the muscle force and an increase in duration of expansion phase, a muscle force rather than back. So when you do a wrong, you don't train them appropriately, there's going to be increased muscle power required to stand up. The patient might topple or fall. The ground reaction force is not appropriately pushed, so the balance is lost. This is the reason why I'm talking about. So the patient has got fall. Normally, I say getting up from the chair or from the wheelchair. He falls in why? Because we have not taught them appropriately. So teach them the first position is teach the patient, or even it's not even the hemiplegic. For old age people, they are supposed to keep the foot behind the 90 degrees lineup so that they get a good reaction force, ground reaction force, and they get a good push up from the floor. From when the thigh leaves, they get a good balance. And said here, ankle should always be 75 degrees. As I said, approximately, is more effective. And what I say one here is that the muscle that normally goes for an adaptive changes is soleus muscle. So we normally physiotherapists, we are stretching the muscle in many ways. In stretching the soleus muscle, we say it's a short, quick stretches, long stretch, and make the patient to stretch a long time. When the patient does this functional movement, patient will not have to do it passively. You can do it actively. So emphasize on this movement so that patient or the person stretches the muscle by himself, so that your half the work is done, and moreover it is active. So the patient does actively, you don't have to do it passively. Don't stretch it. So this acts as an self-stretching, or it's going to be a functional stretching in a patient with a stroke. So I said here, next problem is timing. Now the patient is having difficulty in getting up. It takes a long time. When he does it for a long time, the chances for a muscle contraction. So the speed is really appropriately taught. So don't make a long duration from sitting to standing. Not a fast movement is required. Give him appropriate phases to do this. It is evident that a timing relationship between flexion of the trunk at the hip and onset of the lower limb extension may be critical features of movement organization. So organize them appropriately. Let the ankle move backward, or your lower foot go backward. Let the trunk move forward along over hip. Then let the patient try to move his hip or the thigh move away from the chair. Next is the extension phase. Make sure that there's no pause at all in this. Extension phase in STS starts at the knee while the trunk is still flexing at the hip joint. So no pause is really required in this stage, because I said here already the muscles are working enormously. They're contracting more than the normal. They're contracting 150 times than the normal in climbing up the stairs. I said here, climbing up stairs requires less muscle contraction, whereas standing up from a chair requires more muscle contraction or more activity. When muscles work or stability requires more. So make sure that there's no pause between in the extension especially. The peak hip angular acceleration has been found to occur simultaneously with the onset of knee extension. Smooth continuous transition from pre-extension and extension phase that occurs as a result of inner segmental coordination. That here, don't break the extension phase. Make the patient move simultaneously as we do. Leg goes, automatically I said the body moves forward. Along with this, then moves up the vertical movement of the body happens. Means that the ankle and the trunk moves simultaneously. This is the pre-extension phase. Extension phase is when the body is moving upwards, means that when the thigh leaves the seat and the base of support becomes the foot. So there should be no pause, there should be no much of, what do we say, there should be no gap, or there should be no rest between these two phases of extension phases. The force over the three joints, I say hip, knee, and ankle, or the three joints I'm talking about, was produced for longer when the patient stood up from 60-degree position. That is, without a facilitatory effect of the hip flexion, then with the movement started with the trunk erect. So I said here, always try to have a preferred speed. Don't do a slow or a fast extension phases. That will hinder the patient's muscle contraction. Or patient, you're not teaching the patient a good extension phase. So let the speed be preferred for an smooth movement. So always one thing I like to emphasize here: when you are going to make the patient or person stand, will the patient be able to push? No, the patient will not have muscle contraction. We rock the patient slowly. It means that the physiotherapist will be moving the patient's hip. He's going to be able to roll the patient on oscillation, and we slowly we pull him up so that he comes very in a smooth manner. Yeah, you pull him one stage, it's very hard for you. You damage your muscles or you damage your back. To make this easy, we rock the patient so that the patient's body is rolling over the patient's hip. Then one momentum, we pull the patient. It's easy for the patient to make him stand. So what happens in fast movements? Increased hip flexion as an increased velocity. Extension of hip lower limb happens drastically, which we don't want. Slow, what happens? When slowly move, longer period of time was spent in producing high level of support force, and the effect of reduced velocity of the trunk movement and therefore momentum on production of low limb muscles. So muscles already been struggling to contract. You make it very slow, so the muscles will die. To prevent this, we do an preferred speed better rather than doing it fast or doing it slow. I say fast means the muscle is not preferred. Slow, you are torturing the muscle, or you are giving overloading the muscles. So better don't do a fast or a slow movement. You are supposed to do an preferred or an just oscillatory movement, like a pendulum how it goes, just at the same speed. So 30 to 40 degrees of body segment is ideal for an ideal speed. What I say is, you pull the patient 30 to 40 degrees of body segment, means that trunk moves 30 degrees to 40 degrees of flexion. Then you pull him. That's easy and a good idea. And the ideal area is ideal, that what we do. The forward and upward movement without pause. I say here, don't give them any rest at this stage. When you started to, the patient moves his body forward, the same speed you will be pulling the patient. Don't break the phases. There should be no pause between the pre-extension and the extension phase. So keep in mind that the body moves forward 40 degrees. That's the right time to pull the patient forward, and there should be no break between the pre-extension extension phase. Means that then the body is about to leave the thigh, no gap. Just make the patient erect. So one thing about is next is patient's seat height. Many studies shows that when the seat height is lower, muscle contraction is going to be greater. So at the initial stage, Make sure that the seat are going to be at a greater height. As time progresses, you want to increase the patient performance, then let the chair height be reduced. The seat height can play a significant effect on performance. So seat height is one of the key factor when you train a patient. When a patient is already got a problem and you make him to rise from a slow stool or something, this will make him hard. Better what I do, I make the patient, train the patient first with an higher height of the seat height, and slowly I bring down the seat height. Many studies shows that 50% decrease in the moment of force at the knee at the lowest to the highest seat height. So I make sure that many research done on this show that a person with a height, a good height seat will perform well than the lower seat. As chair height was increased, peak angular displacement at the knee and ankle will also be decreased. So that's what the key factor I'm talking about is always train in the initial stage. Don't train them at the lower couches or at the lower stool. Train them at the 90 degrees as the patient is made to sit with his foot rested. Do not make him in a low couches or a low stool. Raising seat height enables an individual with weak muscles to practice STS, standing up and sitting down. So as the time progresses, you want to strengthen the muscles. Then you do this. You want to reduce your seat height. This can be appreciated always. Seats need to be high enough to enable individuals to stand up without adaptation. Most weight through a non-paralytic lane. Make sure this is being practiced. So most weight through the non-paralytic lane is what the patient will normally do. So not do this, let the patient take his weight on his paralytic lane. What are we talking about? We almost think the elderly and also the stroke are almost similar. They also have the same problem. The high seats were comfortably to get up from the chair. Posterior back needed more involvement of quadriceps than hip and knee flexion with standard chairs. So make sure that the patient will have a good chair height. That's what we intended to tell this. So what all should I look into? What are the muscles are contracting when I do this activity? When I do an pre-extension test, means that when the body moves over the hip joint, what all happens? There's a hip flexion. What I say, hip flexion is going to happen. There's going to be dorsiflexion of the ankle. So how much is the hip flexion? It's around 30 to 40 degrees. How much is ankle? It's 70 degrees. So when this is done, we can have some muscles contracting. What are the muscles here? We're going to isometric contraction of spinal and abdominal muscles stabilize the extension of the trunk. Along with this, you have the ankle dorsiflexus contraction. Hip, knee, and ankle extensor muscles propel the body vertically in the extension phase. So at this time, activates anterior is active in the early phases. So when the patient is about to leave, when thigh is about to leave, at the thigh off, the thigh is off from the chair. We say it's going to keep extension. It's going to extensors are going to contract. Knee extension extensors are going to contract. Almost both muscles work simultaneously. Means that when the patient is going to minimize his balance or minimize his base of support, this muscles, hip extensors and knee extensors, work together one shot so that they have a good posture and balance. Along with this, the lower muscles at the gastrocnemius and soleus do the same thing. They reflect in adding in balancing the body mass throughout the action. So they play a vital role. The lower muscles, gastrocnemius and soleus, plays a vital role in making sure the balance is being appropriate. So here, before I move over my references, I like to emphasize more on the muscles. So whenever you're going to train a muscle, a pre-evaluation, you're supposed to do an hip flexor muscle strengthening, ankle dorsiflexus, and the pelvis anterior, hip extensors, knee extensors, and gastrocnemius and soleus muscles has to be strengthened or look for its suppleness before you do an standing up training. So these lines and my words are taken from the book for references. Before I finish, I like to just refresh the slides in just in few months. So the idea behind this is prevent fall of a patient soon after stroke. So train them appropriately. Means we have two phases: pre-extension, extension phase. Pre-extension phase is the body moving, the trunk moves forward on the hip, and the thigh ready to leave. Thigh ready to leave the seat is pre-extension phase. Extension phase is when the thigh is leaving the chair, the knee and hip are ready to take the balance along with the ankle. So this is what we say here. So this is what we require. So this is where patient normally tend to have a fall. When you do this appropriately by making the patient to have a good ankle dorsiflexion, the patient rocking the patient on his hip, and there's no pause, the fall of the patient can be prevented. So standing up is really a big task. It's a big task which we normally don't address the patient during rehabilitation. I like to emphasize this. This has to be emphasized in patient's treatment so that the patient's fall is being prevented from the, not because of physiotherapy. We emphasize on this so that we get a good result. So thank you all for listening. Anything to ask me or anything to discuss? So Miss.
Yes, sir. It was a wonderful session.
Thank
Just
you,
a couple of questions, sir.
Yeah, no problem, Miss.
Whether the biomechanic aspects are the same for all age group?
And no. Means that, for example, in case of in older people, what they do is normally the patient uses the ankle, means they're going to use armrest chair, where they use the armrest to push, so the body muscle activities will be taken by the hand, where the lower limb activity is less. You understand? I repeat once again. I think I addressed your question. Let me repeat once again. When in old elderly people, normally our parents or someone, they don't get up directly. They put the hands on somewhere so that the balance or the joint muscles in the lower limb is being not fully active. They use the upper limb to take the muscle power. So in case of elderly people, it's totally different. It means they use totally lower limb for getting up from a chair. The muscle power is reduced. Yes.
Normal dorsiflexion of ankle is 20 to 30 degrees. Is it possible to bring about 75 degrees?
I'm not talking about 90 degree, means I'm talking about 20 degrees from there. I'm not talking about totally. I mean, I'm talking from the 90 degree position. I'm talking from all around the place. It's not from the zero. I'm not talking about zero. I'm talking about 90 degrees. 90 minus 20.
Thank you, sir.
Yes. It's a reverse degree of arrangement.
Over to you, ma'am. Yuvrani, ma'am.
Sir, I think any more questions, audience? It was nice session, sir. So now I request Dr. Divya Mary to deliver the vote of thanks. Unmute Divya Mary.
It's my privilege to have been asked to propose a vote of thanks on this occasion. A big thank you to our chairman, Mr. A.C. Shanmugam, sir, our honorable president, Mr. Engineer A.C.S. Arun, sir, and our respected sir, Kumar, for permitting and providing encouragement to conduct this FGP program, training of standing up in stroke. I'm also grateful to our medical director, Dr. Shah Nawaz Khan, for his constant motivation in our deeds. I would like to take this opportunity to place on record our hearty thanks to Professor Dr. C.V. Sendalnathan, Principal, Faculty of Physiotherapy, for the perfect logistic support and guidance he has extended to us training of standing up in stroke. I also extend my thanks to our vice principals, Professor Dr. S. Veena Alice Kritika and Professor Dr. V. Rajalakshmi, and our senior professors for their enormous cooperation in the organization of this event. I must mention our deep sense of appreciation and thanks to Dr. S. Sudhakar and Dr. G. Ivarani and crew for their involvement and their willingness to take on the completion of the tasks beyond their comfort zones. I may like to express our sincere thanks to Dr. C. Ilancharian for providing an excellent coverage on the topic training of standing up in stroke. Thank you for sharing your analysis from sitting in patients. We are grateful to you for demonstrating the biomechanical description of kinematics and kinetics of standing up from sitting in stroke patients from your vast and challenging experiences. We are all inspired by your words and your great words. We owe you Dr. G. Mohan Kumar for introducing us the most amazing person for today's session. I thank all my colleagues, friends, and all who participated in today's session. Hope you all would have benefited from today's session. On behalf of Faculty of Physiotherapy, Dr.M.G.R. Education Research Institute, I thank you for being with us this evening. It has been great pleasure. Thank you.
Thank you, Divya Mary. Thank you, sir. We'll have the grid photo session now.
Can
Arnie?
you give me a minute to just
Yeah,
thank
yes,
you?
ma'am. Sure, sir. Sure, sir.
Okay. Thank you, Dr. Senthilnathan and Mr. Mohan Kumar, for giving me a good opportunity to share my knowledge and also a good session for me to refresh my or share my knowledge with the physiotherapy fraternity team. So I thank once again for the team for giving me a good opportunity to share the knowledge. And I think the session will be a good, useful session for the students of the staff of our faculties. Thanks for the given opportunity. I thank you.
Thank you, sir.
Thank you.
Oh, ma'am, Yuvrani ma'am.
Thank you, sir. The session was so wonderful and very nice and
Sorry,
useful to us.
what do you say? Bit with the training here. So that was the problem with the
No, sir, that will be there everywhere. So,
sorry for the delay.
it's okay, sir. That's not an issue, sir. That's not an issue. Session was very useful and very wonderful, sir. Thank you. Thanks a lot for accepting our invitation and being with us, sir. Thank you.
Yuvrani ma'am.
Yes.
Yes, before we sign off, please
Can we ask
all the
Srinivasan sir to speak a few words, ma'am?
Yes,
He
yes.
has joined the
yes.
session.
Yes, sir. Sir, please do the honor, sir. Srinivasan, sir. Sir, please do the honor, sir. Unmute, sir.
Good evening, everyone.
Good evening, sir.
Good evening, sir.
Wonderful session we had. And it is a lot of things we have to keep learning. It is very important to update ourselves also because we read long time back biomechanics. We have to update ourselves. The good session for the faculty to learn themselves so that they can teach in a good way. Thank you.
Thank you.
Thank you, sir.
Thank you, sir.
Thank you, sir. Before we sign off, a kind of information to all the participants. Your feedback links will be sent to your registered mail ID before 8 p.m. today. And please do revert back within the stipulated time.